orthopedic surgeon, you must foresee the anticipated complications on the table. Just let me clarify. You must foresee the complication and the change of the treatment plan. Initially, you must take in the consent form. You may require an alternative procedure or add-on procedures. Apart from the procedure you have described to the patient, you can take an additional consent.
Yes, I would like to ask one question. Suppose the patient changes the doctor, treating doctor, just after 10 or 15 days, he is keeping on changing the doctor. Who will be held responsible?
See, you are responsible till patient comes to you. If you change the doctor, goes for the second consultation without your permission, your part is over.
Our part is away, but he brings all the doctors in that periphery and he prosecuted. And we have seen a case of Dr. Saha very recently in TV and newspapers also.
See, you have to make responsible what you have done.
We have done, you know.
What you have done. Dr. Saha, what he has done, he is made responsible for only that.
Only 3 doctors, you know, preliminary doctors.
Yeah.
You know.
Yeah.
But before that, after that, you know, I had a case against me in National Commission, which I fought for.
And we begin this session, and I invite Dr. Sanjay Rastogi from Kanpur to present his paper.
Mr. Chairman, I am grateful to the organizers for keeping this topic, joint preservation, in an era where everybody wants to be a joint replacement surgeon. The objective of this talk are to understand that the joint overload can be significantly reduced by realigning the extremity. Improvement in open wedge medial high tibial osteotomy technique in the last decade has improved a lot because of exact preoperative planning, atraumatic surgical technique, and promoting osteogenesis without loss of correction with angle stable implant with correct amount of elasticity. This work has been possible by the contribution of Dr. Coscino, Dr. Stabli, and Dror Pele. We all know mechanical overload of a joint compartment leads to cartilage damage and degenerative joint disease. Deformity of the lower extremity are pre-arthritic. Juxtaarticular osteotomies are established procedure for restoration of physiological axis and treatment of varus valgus juxtaarticular deformity with osteoarthritis. The corrective osteotomy has been proved of use in patients under 40 years of age in a long follow-up up to 38 years, where the osteoarthritis was prevented and only 2 out of 57 required joint replacement. A long follow-up of up to 28 years in high tibial osteotomy for osteoarthritis knee, there was a consistent improvement in knee score and functional score. And last, the regeneration of the degenerated articular cartilage has been shown after osteotomy after 2 years. These are the pictures in which there is complete eburnation, grade C4 type lesion, and there is a stage where it has been completely covered by white fibrous cartilage. This is another picture showing the same. Besides clinical examination, we must take full-length X-rays in which the patella is centered, and this is important to avoid malnutrition, to know the exact amount of arthritis and joint alignment. Patients who have congenital metaphyseal varus deformity of tibia of angle more than 5 degrees respond better to high tibial osteotomy, and the incidence is higher in Asian population. Thus, the ideal case for a high tibial osteotomy will be physiologically active patients up to 85, 4 years have been operated successfully. When patient has tibia vera congenital more than 5 degrees, has intact lateral compartment, has almost normal range of motion, 20-degree flexion deformity can be corrected by surgery. He should be non-smoker because it leads to delayed union. He should have some tolerance for pain. In VAS scale, a patient might have up to 1 grade of pain. Patients with ACL and PCL deficiency can be addressed by surgery, and obesity is not a contraindication. While we plan our cases, we have to be careful. Then pain should be only localized to the medial side in joint line, should not be present away. There should not be any advanced degenerative changes in the patellofemoral compartment, and the subjective pain should be below 6. In pre-operative planning is important, and we must plan that at the end of the procedure, the weight-bearing line should pass through the Fujisawa point, which is 2.5 degrees from the medial side. We have to be careful about maintaining a good tibial slope. The normal is 10 degrees. In patients with flexion deformity or ACL insufficiency, marginal decrease in slope can be done, but it can be marginally increased to by 5 degrees in patients with recurvatum deformity or PCL insufficiency. To do this procedure, one stage internal fixator frame is available, which has 4 proximal and 4 distal angular stable screws. This was first invented in 2000. Asian version was available in India in 2010, and an opening wedge of up to 22 millimeters without bone graft or any substitute can be done successfully. It provides improved stability. There is a medial support by the implant. There is a ventral support by the tibial tuberosity. On the lateral side, there is intact bone, the hinge, and posteriorly, the screws are spanned, and proximally, the screws are spanned to give a broad support. For operating these patients should be supine with lateral thigh support and foot pad to stabilize the extremity in flexion and extension. The contralateral hip should be lowered for a lateral view. We must mark the bony landmarks and the important structures in 90-degree flexion, which is the joint line, proximal part of the pes serenus, tibial tuberosity, and the medial border of ligamentum patelli. The incision is given, a laterally based fascio-periosteal flap is raised, the proximal border of pes serenus identified and retracted to visualize medial collateral ligament, which is erased distally to avoid compression and pain later on. The osteotomy should not be too low because it gives less correction, and it should exit from the point of joint to the upper end of the tibiofibular point. 2 wires are passed in the mediolateral direction parallel to the tibial slope up to the lateral cortex. 1 wire is passed anterior-posterior parallel to the tibial slope, which defines the proximal limit of the plate. This is the first wire, second wire, and the third wire. These wires are put up to the lateral part. The osteotomy is done with new wide 90 mm blade, which is 0.9 millimeter thick. Thicker blade should be avoided, and the posterior part should be protected by a bone lever. Attention to be paid to cut the posterior medial hard bone. It should be done slowly, and a transverse osteotomy, which is parallel to the tibial crest, is made at the junction of anterior 1/3 and posterior 2/3. It should be done in an atraumatic manner by slowly sawing using new blades under constant cooling with little pressure, and this is the immediate MRI. It only shows hematoma at the osteotomy site. At the 3 weeks, there is some reactive edema, and this is the new bone formation at 6 weeks time. So there has not been any trauma to this bone. Now the osteotomy is opened by inserting chisels gradually, and this opens up by fissuring at the lateral side, which is usually exit at the point of epiphyseal scar. The biplanar osteotomy reduces the risk of undesired rotation, translation, and slope change. The correction is checked on the table in complete extension with patella centered on the femoral condyle. Fine tuning can be done and the finally plate is positioned with the solid plate segment over the osteotomy. First 3 proximal holes are fixed in a locked position. Then a neutral lag screw is passed in the first hole in the distal part. This leads to, first brings the distal fragment close to the bone, it pre-tensions the plate, and third, it compresses the hinge. This all adds to stability. Final fixation is achieved, hematoma is preserved, final correction checked under C-arm. Leg which has more symptoms should be operated first. The other leg should be operated 6 months later so that the patient is mobile functionally. The patient have shown consistently good results with VAS up to 0.5 to 1.5. Patient regains full weight bearing at an average of 10 weeks without any support. There is no neurological deficit seen, and only 3 patients out of 707 required knee replacement by the Stabile. And for this reason, I propose a self-examination by patients in which patients who have tibia vera, if they develop symptom or if they can be educated, a preventive osteotomy could also be done. The take-home message would be overload medial osteoarthritis knee in physiologically active individual is the most common indication for open wedge medial high tibial osteotomy. Primary and secondary stability is achieved by preservation of fragment vitality by minimal soft tissue dissection, bone resection, gradual opening of hinge, compression of lateral hinge, and stable fixation by angular stable implant. Thank you for your attention.
Thank you, Professor Rastogi. The paper is now open for discussion if there are any questions. Thank you, sir.
Sorry, 3 speakers are there. Kuch nahi hai zyada. Up, down. This is up, down.
Well, dear friends, my talk for today is basically how we can delay or avoid the surgical management, that is the HTO or the total knee replacement, the different treatment options which are non-surgical available with us. So as we know that for most of the surgeons, orthopedic surgeons, we know that knee pain or the low back ache, this is the maximum patients one gets in their OPD. And as the life expectancy is going on, increasing, we are seeing arthritic children looking after their arthritic parents. Different risk factors, as we all know, and they are slightly different in Indian scenario, where the social habits of squatting on the grounds, they add to the problem. And of late, we are seeing that even the females, especially lesser than 40 years of age, they come to us with knee pain, and at least 10 to 15% of them, when we get the AP scanning views, we get at least grade 1 or grade 2 osteoarthritis, which is the primary one, the really area for concern. And probably, I think that the excessive use of fertilizers, pesticides, insecticides is taking a lot of toll on the human body, and there is a definite need to study the effects of these things on the human body, on the bone or the joints as well. We get the AP views in standing position and grade the osteoarthritis as per the Carlgren-Lawrence grading. And the pain is the most cardinal symptom for which the patient comes to us, insidious and then gradually increasing and then ultimately at rest also. And the first and foremost complaint for the patient is that they cannot climb down the stairs or they get difficulty in getting up from the ground. So we must understand the different causes for the pain in osteoarthritis knee. So subchondral bone is the largest culprit, then osteophytes, ligaments, joint capsule, surrounding periatrial muscles, they also get the heat, get inflamed. And I strongly believe that the cartilage debris, the degenerative debris which are in the joint, They cause the mechanical, also the chemical irritation, and are one of the major factors for the pain. Now these days, it has become a fashion for going total knee replacement. I have seen the patients with even grade 2 osteoarthritis being subjected to total knee replacement. Obviously, the procedure is quite lucrative economically, both for the doctors as well as for the institutions or the hospitals for which they are working. But as the life expectancy is increasing, and if a younger patient gets this TKR, and there probably a lot of revision will be needed in the future, and if something goes wrong, then the total things become very bad and difficult for the patients. So biggest challenge in OA is to relieve the pain, and how we can make the patients comfortable. So I strongly believe that we must strive for the non-surgical management of this degenerative pandemic, and especially the younger ones. And the aim should be to avoid, at least, if we cannot delay it, or at least delay the inevitable, that is the total knee replacement. As long as we can make the patient comfortable without the major surgical procedures, and the patient is happy having no pain, we should strive for these procedures. And surgical management should only be indicated when all these measures have failed and the patient is not satisfied and is not pain-free. So the different treatment modalities, I will just go in brief. So first and foremost, we always put the patients on anti-inflammatories or analgesics. Different things are available, safer ones, gastro-friendly. Now a big basket of disease-modifying anti-osteoarthritic drugs are available. They are, some call it chondroprotective and chondro-regenerative drugs. They have to be taken for a very, very long duration, maybe a few months, and maybe more than that. And the first one comes to us is the glucosamine and chondroitin sulfate. So basically, they stimulate the chondrocytes to make the proteoglycans and inhibit the cartilage catabolic enzymatic activity, and hence they are thought to retard the process of degeneration. Then there's the diastrim. Basically, again, it slows down the process of degeneration by inhibiting the interleukin-1 synthesis. It also enhances the expression of TGF-beta-1 and beta-2, so thus favors the matrix synthesis and turnover in the articular chondrocytes. Another medicine available with us is S-adenosyl methionine. It increases the proteoglycan synthesis and helps in forming the cartilage. So this is thought to be regenerative for the cartilage. Now, a lot of many companies are coming with collagen peptides. Basically, it is thought that the matrix part of the collagen is increased by these collagen peptides, chondrocytes and the matrix, and it helps to increase the matrix aspect, so it thickens the cartilage. Then another drug is cetyl myristate, that is CMO. It came into light in mid of the 80s in USA. If the rats, they say that they don't suffer from osteoarthritis because the CMO level in their blood is extremely high. So probably taking a cue from this, it was being used in, started being used in osteoarthritis knees. And basically it is a very, very strong antioxidant which helps in preventing the cartilage degeneration. Rosehip extract is also coming to the market from Rosa canina. This again is being strongly antioxidant. Then a lot of people, and actually all the patients themselves also use the topical applications like capsaicin, methyl salicylate, nimesulide, etc. Basically, they don't have any effect in the degenerative osteoarthritis itself, but the surrounding peripheral inflammation is decreased by them, and the patient has a sense of having decreased pain. Steroid injections were being used quite extensively in earlier era, but these days I don't think much of the orthopedic surgeons are using the steroid injections, but even if they say it is to be used, it should not be used for more than once a year. Again, the action which they do is probably anti-inflammatory, which causes the pain relief for some time, but still again, the exact action, what it does in the cartilage itself is on the large, not much known. The second aspect is the non-pharmacological, non-surgical management, and this is the most important aspect for any patient suffering from osteoarthritis of the knee. This is the physiotherapy. Basically, I always tell that if the tent is to stand erect, its strength has to be very strong. So if the joint has to be good, the muscles have to be good. So for that, the quadricep strengthening and the hamstring stretching exercises are very, very important for all these patients to have a long-term benefit. Again, the weight loss definitely improves the function. The people having some genoverum, slightly, they say that lateral shoe raise can help to offload the stresses on the medial aspect. Walking, cycling, and swimming, again, are very good exercises to develop the muscles. In acute cases, we must give them the rest, and otherwise, the full range of joint motion must be practiced by the patient so that the capsular contractures, they don't occur. Different knee braces are good for the patients to walk around. They give some support. Then paraffin wax and the moist sheet, again, they act as anti-inflammatory agents. Traction, if the patient is having severe pain and may get the contracture formations, to prevent the contracture formations, the patient must be put on traction for some time. And in acute exacerbation, ice packs are needed. The lifestyle modifications have to be told to the patients that they have to stop using the excessive stairs. They have to stop sitting below the chair level, which will lessen basically the factors which are causing more degeneration to the knee joint. Some people are practicing knee taping. Basically, it is just a temporary procedure to give pain relief for some time. It realigns the weight transmitting forces from the extensor apparatus. Viscous supplementation has come with a big bang. It came, and probably still many people are using it, but I am not I don't favor it very much because its effects are very short ones, maybe from 3 to 6 months. Then the rotational field quantum magnetic resonance therapy, RF-QMR. Okay, sir. Just give me 2 minutes. So one of the Indian scientists from Bangalore, it changed the MRI machine to the cytotron, and they say that proton spin is changed across the cell membrane and the regeneration of the cartilage starts. I do a lot of arthroscopic lavage so that the debris are gone from the joint, so that one of the major factors for the pain is gone. Now, orthobiologics, which is the thing for future and is coming up extensively, that is the biological solutions, use of stem cells and the growth factor-rich plasma. I'm using it for the last 3 or 4 years, and I have injected the PRP, the growth factor-rich plasma, in more than 500 knees with very good results. Stem cells means basically totipotent, pluripotent, or multipotent. We are using the multipotent stem cells are most easy to get. That is from the bone marrow itself. Mesenchymal stem cells can be separated and they can be injected into the knee joint to have the cartilage regeneration. Now this is a beautiful slide. Most of you must have seen, whenever you take a loose body from the knee joint, it is always surrounded by cartilage, whatever the age may be. But otherwise, for the degenerated joint, no cartilage is found at that area. Why so? So probably the knowledge of regions and the phenotypic characteristics of the progenitors and the controlling factors is not known. Why it happens so? But definitely inside the joint, the potential is always there to make the cartilage. How to excite that potential, which we do not know. Probably the use of the stem cells and the growth factor-rich plasma is going to help to unlock this problem. So if stem cells are the seeds on the lawn, the PRP is the fertilizer. Growth factor-rich plasma, So basically, in the alpha granules and the platelets, they contain a lot of growth factors. This is enumerated over here. And these growth factors, when injected into the joint, they stimulate the cartilage. They attract the stem cells, mesenchymal stem cells, and they stimulate the cartilage cells to be reformed. I started using in 2010 more than 500 knees. This is how I prepared. This is double centrifugation is done, and basically PRP is 5 to 7 folds increase in that concentrate. I take 100 ml of patient's blood. It is double centrifuged, and we get around 15 to 20 or 18 ml of the PRP-rich plasma, and then we inject into the knee joint. I've used this PRP in non-unions, in restrictive shoulder orthopathy, and many other tendinous conditions. But the maximum use I've done in osteoarthritis knees, more than 500 patients. So, last 3 slides, my choice for the combination therapy is for the grade 1 and grade 2. I start with NSAID so that the patient is comfortable for a few days. Then I do the knee lavage, and we start the disease-modifying anti-osteoarthritic drugs. Physiotherapy is also started, and after 3 weeks, I inject both the knees with growth factor-rich plasma. And this combination for grade 1 and grade 2 knees has done wonders for them. The patients, even after 3-4 years, they are coming to us without having any pain and without the need for having analgesics. For grade 3, this earlier applications whatsoever I told you, they can help to some time, but in these cases, HTO may be indicated. But for grade 4 cases, I always tell them to go for total knee replacement. And obviously, if the patient has to buy some time, then all these 3 measures, knee lavage and PRP injection, physiotherapy, etc., they have to be started, and the patients are quite happy with that. You must have seen that many even patients having grade 3 or grade 4 osteoarthritis, they don't agree to get the total knee replacement. So for these people, to buy some time, these procedures are very, very helpful, and still this PRP and stem cell therapy are in the very younger stages of their research, and probably as the time goes on, many things may be unfolded, and the era may be there when there will not be any need for the total knee replacement, and such stem cell therapy can help all these patients. Thank you very much.
Right, good afternoon. I'm going to talk about how do we deal with valgus deformity when we planning to do a total knee replacement. Fortunately, incidence of valgus deformity is quite rare. It accounts for about 5 to 10% of all osteoarthritic knees. It's common in females, probably because of wider pelvis or increased tibial external torsion as compared to males, and is common in inflammatory arthritis, particularly rheumatoid arthritis. Clinical assessment is absolutely important. We need to see whether it's valgus alone or it's associated with fixed flexion deformity. Now, whether the valgus deformity is correctable or not, assessment of adjacent joints, especially feet and hip joint, is absolutely important. If there is any hip arthritis, you deal with that first. And maybe sometimes foot deformity needs to be tackled first because it can put abnormal stresses on your knee replacement. Then we do radiological assessment, and then sometimes arthroscopic assessment when patients' symptoms are out of proportion to radiological picture. If you do routine AP X-ray, you may find joint space is not too bad. It might look like it's not grade 4, but when you do PA weight bearing with 30-degree flexion, it's very important, especially for valgus deformity, because most of the wear is on the posterior part of the lateral femoral condyle. And if you do a standard AP weight bearing, you may underestimate osteoarthritic changes, particularly in the lateral compartment. And if there is any doubt, and if the symptoms, if this patient has been managed conservatively and it still has symptoms, and you're not convinced this patient has grade 4, it's worth having a look through arthroscopy, and very often you will find grade 4 changes on the posterior part of the lateral femoral condyle and the tibial plateau. What happens, what changes take place in valgus knee? A deformity is usually on the femoral side. Typically the lateral femoral condyle is deficient. Femur is internally rotated, tibia is externally rotated, lateral orientation of the tibial tubercle, which can contribute to patellar maltracking, lateral and posterior contractures, and there is medial stretching, and ligament balancing is difficult. So the management goals, as with any total knee replacement, is to have balanced flexion and extension gaps, restoration of mechanical access, stable functioning knee, and good patellar tracking. So how do we correct the valgus deformity? It is with bone cuts, some adjustments in bone cuts, stage soft tissue release, and very often combination of two. How do I approach? Most of the time I'll use medial parapatellar approach, and I'll make sure I don't do any medial release, because most of the time you're dealing with varus knees, it becomes a habit to do some medial release, but make sure you don't release anything medially. And occasionally I would consider lateral parapatellar approach, especially if you are expecting significant lateral retinocular release, because if you have used medial parapatellar approach and you have to do lateral release, then that patella has got no blood supply left at the end of the procedure. So it's worth keeping in mind. So it's useful in certain cases, and it allows easy release of ITB from Gerdy's tubercle in severe deformities. Like you do medial release through medial parapatellar approach, you can release whole of the ITB from Gerdy's tubercle. And as I said, division of lateral retinoculum as a part of your approach helps with your patellar maltracking. However, there are difficulties with that. That's why a lot of people don't use it. Patellar retraction is difficult on the medial side, and there could be difficulty with tibial cut. So you've got to be aware that you do not end up cutting the patellar tendon. It's right in your way. So sometimes people add lateral parapatellar approach with tibial osteotomy. I personally don't like to do that. Valgus knee. So if you've got valgus deformity, you first work out whether it's correctable or it's fixed deformity. If it is correctable, you can proceed as routine TKR. You use whatever you're comfortable with, but again, making sure that you don't release any tissues medially. However, if it is fixed deformity, then you divide the PCL, remove the osteophytes, and at this stage, I don't do any more soft tissue releases. I would proceed to bone cuts. Bone cuts, how do I do it? I do the tibia first. To get a reference, you cut the tibia parallel to the ground, and that is your reference. And then I do the anterior posterior section first to fix my flexion gap. It's much easier to fix the flexion gap in valgus deformity than the extension gap. And you can use either posterior referencing jig or anterior referencing jig. I personally like to use anterior posterior referencing jig. And you would see there is minimal or no cut from the lateral femoral condyle. Valgus knee. Now when I go to distal cut, and I've heard through the kind of in this conference or last three, a lot of people like to use 3 degrees. I'm not sure why. I would prefer to use 6 and sometimes even 7 degrees. If you're using 3 degrees, you are taking more of the medial femoral condyle, which increases the gap on the medial side, and you end up doing huge amount of release on the medial side, on the lateral side. So I would go up to 6-7 degrees for severe fixed valgus deformity, because then you take very little of the medial femoral condyle, and you just probably skim through the lateral femoral condyle, and you'll find you will never have to use bone graft or any augments if there is severe defect. Now, the distal femoral cut should be conservative because MCL is already stretched, and you will find if you have taken usual amount of distal femoral cut as you would do with the varus knee, you might end up with increased gap, and then you suddenly have a gap disbalance between flexion and extension gap. So I'll be very conservative with that because of stretched MCL. And if there is any flexion contracture, that's not because of light tight lateral structure, but the posterior structure, and most commonly is the posterior osteophyte or the posterior capsule, which you release from the back of the femur, and sometimes you can even cut the posterior lateral capsule or posterior medial capsule as well to correct the flexion contracture. So if I've got the, so I'll look, once I have done my AP cut and distal cut, I'll look at flexion extension gap. They are either equal or unequal. If they're equal, then you proceed as routine total knee replacement. If they are unequal, then you have to look which lateral structures are tight. If it is tight in extension, then you release ITB band. If it is tight in flexion, then consider releasing lateral collateral ligament and popliteus of the femoral attachments periosteally. Be aware, if you're releasing lateral collateral ligament and popliteus and using a mobile bearing, it can cause flexion instability. So if you're doing ITB release, pike resting is probably the method of choice, which is basically you make multiple stab incision in the iliotibial band, which stretches out, or you can release it of the Gerdy's tubercle if your approach allows you to do that. If you're releasing lateral collateral ligament and popliteus, be aware of flexion instability. So I think all these soft tissue releases are done in the stages. Once you have done a bit of soft tissue release, check your extension gap. You don't want to be in a situation where you suddenly release quite a lot on the lateral side. If there is any residual instability, be prepared to use constraint or hinge knee. So that's an example of a valgus knee. It is correctable. There is no fixed deformities. Unicompartmental osteoarthritis. I feel confident to put unicompartmental knee replacement. If it is non-inflammatory in origin, but I'm sure lateral unicompartmental is not that commonly used, probably because of low incidence and also because it has not shown very good results, particularly the mobile bearing because of risk of dislocation, but total knee replacement is equally good. If it is valgus knee with correctable valgus in a rheumatoid patient, I would use a standard knee replacement. You can use whichever you want. I prefer mobile bearing. If you got severely fixed deformity, something like this, you can see big osteophytes all around the knee and severe fixed deformity. But interestingly, if you look at the medial joint space, it's not that open out. So you still feel that medial collateral ligament still has got some stability there, and you would probably plan for routine knee replacement like this one. If you got severe valgus deformity, then you got to be prepared for more constrained type of knee replacement, either varus valgus constrained knee or a rotating hinge knee replacement. Now here you can see the medial compartment is started to open. This MCL is not is pathological. You cannot rely on this MCL with your routine knee replacement, so be prepared to change into a more constrained type of knee replacement. There is talk about advancement and imbrication of MCL. I personally don't do it. Imbrication, because I'm not sure about the quality of that ligament. You're just shortening and then you're relying on the scar tissue to provide you stability. Advancement, I'm not sure about what is the isometric point. If you take a wafer of the medial femoral condyle and just move it up, you may not be fixing it on isometric point. And then there may be issues about post-op rehab. And if you got this kind of severe valgus, then you know MCL doesn't exist. There is no point trying to do anything else. Just go for rotating hinge knee replacement. Thank you.